là pour 6 mois pour une mobilité. Elle est américaine. Elle travaille à l'université de Alabama Birmingham et elle vient avec une bourse Fulbright. Elle est associée professeure là-bas. Et elle a travaillé énormément dans la Cohort Study, qu'elle va vous présenter là, depuis plus de 10 ans, je pense. Et très bientôt, elle va devenir PI de cette cohort. Donc voilà, elle va vous présenter une grande partie de ses recherches conduites là-dedans, en particulier sur la nutrition et le risque d'AVC. Et puis maintenant, Suzanne, elle étend énormément ce qu'ils font dans les gardes. Elle va notamment développer de la recherche sur la démence.
Merci, Cecilia. Most of my talk will be in English. I understand French. I can understand when people speak to me. It's much harder for me to speak it back, but that's part of the process here. I'm trying to learn more French while I'm here. Most of my talk and most of what I do in the Regard study is on diet and social deprivation, neighborhood characteristics, and how the neighborhood influences health. And today we're going to talk about how those two factors might influence racial disparities in stroke. But before we go there, I probably have to convince you that there are racial disparities in stroke in the United States. It's very unique, the way that stroke is distributed in the United States. We have both regional and racial differences in stroke and who gets stroke. The first thing we'll talk about is the stroke belt. This first part, the stroke belt. The belt is literally what goes around the waist. We call it the belt because it's a region of the US where there's very high stroke. And then also the excess stroke in African Americans. So the first question you might ask me is, how bad is the stroke belt? Is it actually a bad place to live in terms of stroke? Well, the CDC, we actually don't have great data in the United States for determining how many strokes we have. Every state, all 50 of them in the United States, tracks stroke differently. And within every state, every county tracks stroke differently. So we don't have a good national estimate of how many strokes are out there, but we do know who dies. So if somebody dies, we know if they died of a stroke, and the CDC tracks that, which is the Center for Disease Control. They track those data for us. And you can see right here, there's a very dark purple section. That dark purple is our high rates of stroke, and we call that the stroke belt. There's no real definition of the stroke belt. Loosely, it's these 8 states in red, one of which is Alabama, where I live. Alabama is right down here. And it usually includes these 8 southern states. Well, how bad is the problem? We can use the CDC data to guess at how bad the problem is. We can estimate the rate of death in this population, which is about 52.3 per 100,000. If we look at the rest of the nation, they have strokes at a rate of about 44.8 per 100,000. And so that means that the rate in the stroke belt is about 17% higher. Why does that matter? Well, that means that there are actually 19,000 extra deaths that are occurring in the stroke belt that are not occurring outside of the stroke belt. And to put that in perspective, we're looking at the cost of it, because I'm sure it's the same way in France. We always have to sell money and why it matters. These extra deaths are associated with extra strokes. At least that's our hypothesis. That means there are probably 12,000 to 13,000 extra strokes in the Southeast that don't happen in other parts of the country. In the US, every stroke costs about 140,000 US dollars. So that particular excess risk of stroke is associated with a $1.8 billion public health burden. That's something we can go back to our legislators and the NIH and say, well, we can do something about this. If you sat and thought about it, why would you think more strokes happen in the southern part of the United States? What might be the reasons for it? Lots of people have speculated that there are a multitude of factors leading to it. I, of course, focus on lifestyle choices, but most people believe that it's something related to risk factors. Hypertension, diabetes, obesity, all of those factors are higher in the southeastern United States. We have a joke that we like to say in our study, that there are lots of different hypothesized causes, and they range from unlikely to uninvestigated. because every time somebody looks at one of these causes, whether it's SES or quality of healthcare or infectious disease or genetic, it turns out that that is not what's causing this excess risk of stroke. What about African Americans? I hinted at that earlier, but we also know that African Americans have a higher rate of stroke than their white counterparts. And I think that the statistics are the same in France that they are in the United States, that in the past 40 years, the rate of stroke and the rate of heart disease have declined. So we know overall health is getting better in terms of chronic diseases and chronic disease burden. But in stroke, you can see the orange lines represent African Americans, men and women. You can see in stroke, both of those lines still reside above their white counterparts. In the heart disease category, the two lines that are on top are men. Men have more heart attacks than women in the United States. So there are gender disparities. But in stroke, it's a race disparity. And although there are fewer strokes, the frustrating thing for our cohort, for our investigators, is that the ratio, the relative risk of having a stroke for blacks and whites, that gap has actually widened. So while everybody is having less strokes, African Americans are still having more strokes, and the rate at which they're having more strokes is growing. It's not decreasing. So that's another public health problem. We're looking at a 37% increase in the disparity in the past 30 years in men and a 24% increase in the disparity in women. When we look at that, again, going back to what that means for deaths, the deaths are not spread equally. In fact, if you look in the oldest old, those above 85, there really is not a big difference in the number of African Americans that are having strokes and then going on to die versus their white counterparts. But in younger populations, it's very high. That's where the bulk of these deaths are occurring. And that's particularly alarming because it leads to loss of life, loss of mobility, loss of cognitive functioning, and it's a pretty big burden in the African American population. But again, that's not how we can sell it to our lawmakers. We have to sell it with money. So applying the same logic that we applied before to the regional differences, we see there are about 6,000 extra deaths in African Americans. This is projected to be associated with 23,000 extra stroke events. And again, the cost of the stroke is $140,000. Well, this is associated with a $3.2 billion cost to the US healthcare system. That's a big cost. That's a tangible cost. It's about what an aircraft carrier costs. So if we can tell Congress, we fix this issue and you can have another aircraft carrier, they come back and say, okay, we'll fund you. And that was basically what we said to get funded originally. What are the reasons why there is excess rate of stroke in African Americans? Hypertension is one of the biggest driving forces. Diabetes in the United States does not appear to be, but hypertension is definitely one of the strongest predictors. But low SES is also something that has contributed to the excess risk. Like I said, we don't have incidence data. All we can look at is mortality. We do have this group in Cincinnati that does surveillance just for the city of Cincinnati, which includes part of northern Kentucky and part of Cincinnati. And they have shown us that the rates of stroke incidence are roughly the same between blacks and whites in terms of the disparity. So the high mortality is being driven off stroke incidence and not necessarily that African Americans aren't getting good stroke care, so they're more likely to die. So we set out to do this cohort called Regards. I hope I've set the picture for you that the problem is complicated. There are racial differences, there are geographic differences, and when we started out with the initial power calculations, we realized that we would need about 700 stroke events in order to test the hypothesis of how does blood pressure lead to a different risk of stroke in blacks versus white. It's an interaction hypothesis. It means you have to have lots of events. So we look at the other big cohort studies in the US. The Health Professionals Follow-Up Study in Nurses Health, they had accumulated about 480 strokes over 9 years. Framingham, it took them 34 years to get the same number of strokes, 450 strokes in about 34 years. Eric had 299 strokes over 15 years. Mesa, 269 over 13 years. Cardia is another big cohort, but their average age right now is about 55 to 60. They're just too young. They're not having strokes at a high rate. And then the cardiovascular health study was at about 480 strokes in 13 years. And again, remember, we were hoping to get to 700. So we started a brand new study from scratch in 2003. And the dots on this map correspond to where our participants live. We wanted the study to be half black, half white, half male, half female, half living in the southeastern stroke belt, and half the rest of the country. So each dot represents a participant. The red dots represent white participants, and the blue dots represent the African American participants. We recruited a total of 30,000 people into the cohort study between 2003 and 2007. We did something very different than everybody else. When we started doing this and we were trying to sell this to Congress, they told us, you can't do it. You can't recruit 30,000 people into a cohort and get blood pressure measurements and get blood and get a detailed medical history. It's just not possible to do that. The Health Professionals Follow-Up Study and Nurses Health from Harvard, they have done it as well, but they did it by using doctors and nurses where they sent them forms and they filled out the forms and sent them back. We wanted to get people with no medical history, who weren't necessarily in the medical field. So we used the telephone. We called people on the telephone, just the same way that our Center for Disease Control does, and said, hi, would you like to be a part of our study? Here are the benefits for you. We'll come into your home, we'll get your blood pressure, we'll take your some blood to take back to the lab, we'll get a urine sample, and then we'd like to follow you for the rest of your life. Overall, it went fairly well. I think the recruitment rates in France and the US are similar. We got about 33% of the people that we called to say, yes, you can come to my home. Of those people, we got about 80% to actually do an in-home visit. So we were pretty excited. We had to call about 50,000 people to get to our 30,000, but it went okay overall. We got demographic information, major cardiovascular risk factors, the lifestyle variables, which I'm going to talk in depth about diet in just a second, general self-rated health. We asked them about their doctor, depression, and we also have some cognitive functioning data. We were able to do this by contracting with health insurance companies. So in the United States, you can take out a policy for health insurance. And I'm not sure if France has something similar. But the health insurance, not health insurance, life insurance, it's basically if I die, my husband and son get some death benefit to some amount of money that is supposed to be equivalent to my job. In order to do that, the life insurance company wants to make sure I'm not going to die tomorrow. So they send somebody into my home, they check my height, they check my weight, they check my blood pressure, they ask if I smoke, and they try to determine how likely I am to die so they can decide whether or not they want to provide this benefit to me for my son and my husband. Well, we used that same system and said, if you can go into somebody's home and assess if they're going to die tomorrow, you can tell us, what their blood pressure is. So they went into the home for us, but what that means is we have 6,700 different nurses that worked for us on this study. So the quality control is not the same as what you would get from Eric, from Framingham, where you have a centralized study staff. These are individuals who are trained and know what they're doing, but they deviated from the protocol occasionally. We did get written informed consent, which is critical to the research, and also we're able to get an ECG, an electrocardiogram on everyone to look for abnormalities in the heart. We also gave a whole list of packets to people that we didn't have time to administer in the house. One of those was the Dietary Questionnaire. These were self-administered. The participant just filled them out on their own and then sent them back to us. The laboratory is housed at the University of Vermont. So after we collected the blood, we sent the blood to Vermont because it's very cold in Vermont. They don't have to pay a lot for the air conditioning of the facility. And all of our blood is stored there. We have barns, about 4 of them, that are about the size of this room. Just 4 barns lined up with blood and urine waiting to be analyzed. We did do lipids, glucose, CRP, creatinine for kidney function, and some blood markers like hemoglobin and hematocrit for anemia right off the bat. But we save the samples too in case a new novel biomarker needs to be tested. In the ECG reading center, we looked at silent myocardial infarctions for people that didn't know they'd had a heart attack, atrial fibrillation, which is a huge stroke risk factor, and left ventricular hypertrophy, which is a complication of hypertension. We follow them every 6 months. We call our participants still every 6 months. We make about 4,000 phone calls every month just to see how people are doing, to ask if they've had a stroke, to ask if there are any changes in their health, administer new questionnaires, anything else we think we might need to do. Then we retrieve their medical records if they say they had a stroke. Again, in the US, this is complicated. We have people living in all 50 states going to very academic medical hospitals like UAB, like the University of Bordeaux, but they're also going to community hospitals for their stroke, where there might be one physician, and that one physician probably is not an expert in stroke. So we get medical records from all across the country and bring them in centrally and have our neurologists look at the medical records. What we do is every year, the neurologists fly into Birmingham, we take them out for dinner in the nicest restaurants that we have, and then they give us 16 hours of their time flipping through medical records to look for strokes. It was the only way we could do it. It was too hard to look at that many medical records, so that was the way we went with it. We also, after we were funded, the federal government, the US government, came back to us and said, you have the largest assembled cohort of people across the country. You have to follow them for cognitive functioning, which at the time we had no money to do this. They just told us we had to do it. And so we had to figure out, okay, where are we going to cut corners so that we can assess cognitive functioning? Now we're so grateful that we did this, because this has been some of the most rich data that we've had going forward. These are the research sites across the United States. Again, my site is the University of Alabama at Birmingham, right here. But Wake Forest is over in the Carolinas. Cincinnati, which is where the bulk of our neurologists live, is right up here. We have a neuropsychologist here in Indiana, and now another one at Columbia. Jennifer Manley has just joined our group. Vermont is way up here in the cold north. They're the ones that are laughing at all of us for the snow here in France. They laugh at us in Alabama when it snows too, because we can't handle it. And then we have our, of course, our funder up here at Washington, D.C. with NINDS, the National Institutes of Health. One more reminder of what the participants look like and where they live. And then this is a brief description of what the cohort looks like. It turns out we recruited a few people that had had prevalent stroke. So although we have 30,000 people, about 3,000 of them had had a stroke at baseline. So we don't include them in analysis, and it winds up closer to 27,000, 28,000 when we do analyses. They were aged 45 to 105 at baseline, with an average age of about 65. No big racial differences in terms of age. We have so many people in regards, we very rarely report p-values because they're almost always significant, but they're not always meaningful just because they're there. You can see that the black participants do have higher systolic blood pressure than the white participants at baseline, even though they report using antihypertensive medication more. So they know they have hypertension, they're taking medication to control it, and yet their systolic blood pressure is still higher than the white counterparts. The black participants also have higher rates of diabetes over here, almost double that of the white participants, but they have lower rates of heart disease. And we are not the first people to have reported that. White Americans tend to have more heart attacks than black Americans, and black Americans tend to have more stroke. Again, going back to those cohort studies, so you can see, did we do what we wanted to do? We did. If you get to the bottom line, within 12 years, we had about 1,200 strokes. I think the neurologists were just in town in January, so I think they added another 200 strokes, so we're probably closer to 1,400 now. But we have enough strokes now that we're able to test these racial differences to see if there are racial differences in the risk factors. I'm going to focus on the dietary data. After I'm done, you're welcome to ask me any questions about any of the other data we have, but this is what I work with the most. We used a Block 98 food frequency questionnaire. There are two big food frequency questionnaires in the United States. The Willet that you may have heard of, which comes from the Harvard group, and the Block, which comes from the University of California, Berkeley. Those two groups have a very different philosophy about how you assess diet. The Block group had assessed more diet in African Americans than Willet, so we went with the Block food frequency questionnaire. But it's self-administered. They mailed it back to us. We scanned it in and then sent it to California for them to tell us what people were eating. This is the website for the company that processed the food frequency questionnaires, the Block 98. It's called Nutrition Quest. And this is an example of what a food frequency questionnaire looks like. For those of you that don't do nutrition research, Cecilia and I do a lot of nutrition research, so we think about this more than most people do. But when you think about what you're asking someone, when you're asking them what they ate, it's very complicated. We're asking them to think back over the last year. Over the last year, how often do you think you drank tomato juice? It's when you think about it for a minute and you step back, it's not as easy as it sounds to remember what you might have eaten. Then we ask, well, how much? How much tomato juice did you drink? If you said you drank it every day, how many glasses are you drinking every day? Now, tomato juice is not a great example because not many people drink tomato juice, but orange juice would be a very commonly consumed juice, or milk down toward the bottom. It's tough to think about how often you might consume these things. This is just one more section of it. This is the fruit section. Again, very complicated when you think about the fact that different fruits might be eaten at different times of the year. You might eat strawberries when they're in season in the summer and citrus when it's in season in the winter. And I show you this just to tell you the 2 pages that I've shown you, that's only about 25% of 1 page, and they had to fill out 8 pages. So it's about 20 times what you've looked at here. And you can think about how monotonous that might get in terms of people completing and filling out the questionnaire. So it's not surprising that not everyone completes the questionnaire. 30,000 were given the questionnaire. About 25,000 sent it back to us, but about 4,000 of those were blank. They just sent it in completely without filling it out. So we had about 21,000, 22,000 with usable data. I'm interested in dietary patterns, not necessarily specific micronutrients. I've done work in vitamin D in the past and looked at specific micronutrients, but lately I've mainly been looking at diet as a whole and how we characterize diet as a whole. In the United States, we are obsessed with the Mediterranean diet. I don't know why. I think that we want to be here. I'm not sure what it is, but we always take a look at the Mediterranean diet to see how much people adhere to a Mediterranean diet. It was funny, I was talking to somebody near my house in the boulanger, and he said, so what are you doing? And I said, well, I'm gonna look at the Mediterranean diet in France. And he looked at me like I was crazy. He said, you do know Bordeaux's not on the Mediterranean. I said, yeah, I do. Thank you for that. It was very funny. But it reminded me that we use this term commonly, and it doesn't mean what it looks like it means. What we do is we take a look at these individual components that the Harvard group has decided make up a Mediterranean diet: vegetables, fruit, legumes, cereal, bread, pasta, fish, meat, dairy products, and then the ratio of saturated fats to monounsaturated fats, that's trying to get at olive oil, and alcohol. And then they get points. You get a positive point for the foods that are considered good, the fruits and vegetables and fish. If you're consuming a lot of meat or dairy, the participant loses a point. And alcohol also gives participants an extra point. So the score winds up ranging from 0 to 9 for those 10 components. We split it into tertiles because that was the easiest thing for us to do, was split the score into tertiles to analyze it. It's not surprising what you see. Again, there are those p-values, but most of them are significant for the most part. We see that In this particular analysis, income is strongly associated with diet, which if that's the only thing that you take away from here today, know that college education and how much money a person makes is very strongly associated with what they eat. When we look at it in terms of who has a stroke, we see that the adherence to a Mediterranean diet, this is flip-flop, sorry, I was changing it this morning. It should be the high adherence is protective. So up here, these two need to be flipped around. People who adhere to a Mediterranean diet are less likely to have a stroke, even if we adjust for the kitchen sink. And this is true in regards, this is true in other cohort studies. I'm going to put up cognitive function next so you can see that it's also protective in terms of going on to develop incident cognitive decline. Why? It's tough to say. This is definitely not measuring how closely they actually adhere to a Mediterranean diet. It's measuring something else. It's measuring a pattern of eating, but it's the best we have at the moment. In cognitive decline, and those of you that do cognitive decline research, this probably won't surprise you. We only found an association in people without diabetes. That's not surprising given that diabetes in and of itself, having high insulin, can impact cognitive function. So that finding is not terribly surprising, but I do think when you're looking at cognitive function, it's always important to think about diabetes if you're talking about diet, because insulin and high insulin can actually mask what the effective diet actually is. So for me personally, what if I don't want to put a label on healthy diet? I'll write the paper on Mediterranean diet because I'm expected to, and the scientists in the United States want me to, but what if I don't want to use that style of diet? Well, there's another technique you can use called factor analysis, and we talked about this in a meeting last week, and a lot of the faces out here are familiar, so I won't spend too much time on it. But basically, we took the 56 food groups, or 108 items on that food frequency questionnaire, and broke them into 56 food groups so that we could have a more manageable set of food groups to work with. These are the actual food groups to the left with the individual items that might be in there. And then we used a split sample replication. We thought that it would be very complicated to look at dietary patterns in this population. Again, the Harvard group had done this before us in Health Professionals Follow-Up Study with Frank Hu, where you take a factor analysis and you try to reduce the diet down to its primary components. So we wanted to derive the factors in one part of the population and validate them in the other part with the confirmatory factor analysis. We only used foods that had an absolute loading of 0.2, so the lower loading foods were not used. And when we did that, we wound up with 5 dietary patterns. Now, anyone who's done work in this in the past, you'll know that usually you get 2 principal components that you would consider to be important. And we can talk anytime while I'm here about why we decided to choose 5, where on the scree plot they fell. But there was a clear distinction between 5 and everything else. When I put these factors up, you'll see that it can be very challenging to decide what you're going to call a specific food group. You take a look at the items within there and you guess at what type of a pattern a person might be eating. Again, this is not based on health. This is not based on what I think they should be eating, what the United States Department of Agriculture thinks they should be eating. This is just what people are likely to eat together in these factors. The first factor looks to be people that are not cooking much for themselves. They're probably going out to eat, picking up pasta, Mexican, pizza. Those are very common American takeout foods. The second pattern does appear to be a healthier pattern with lots of fruits and vegetables, poultry. And this particular poultry is poultry that's not been fried. The third pattern is somebody who has what we call in the United States a sweet tooth. Lots of sugar, desserts, chocolate, candy, sweet breakfast foods like crepes and pancakes, high-fat dairy. Factor 4 has a lot of fried food, organ meat, eggs, and then the sugar-sweetened beverages. And factor 5 is always one that confuses us with salads and green leafy vegetables, salad dressing, and then of course wine and butter and liquor and coffee. This appears to be a diet for someone who's eating salads for lunch and dinner and then gets up and has some eggs and coffee and drinking alcohol at all of their meals. When we look at these patterns and how they're associated with age in terms of who might be adhering to the pattern, the mean score is an indication of how closely they adhere to this particular dietary pattern. And we can see that younger people are more likely to eat that convenience pattern. They're probably the ones that are still working. In the US, people tend to work until about age 65 on average. The older people are more likely to consume the healthy pattern. We don't see big differences in the sweets or southern pattern, but we do see that the younger people are more likely to consume that alcohol pattern. If we look by race and region, we do see some pretty big racial differences. We see in the convenience pattern that the black participants are much less likely to eat that pattern, but they're much more likely to eat the southern style, and again, much less likely to eat the alcohol style, which doesn't mean they're not consuming it, it just means they're less likely to be adhering to it. Education shows some of the strongest differences in terms of adherence. You can see a really strong gradient with the convenience diet in terms of folks that have not graduated from high school are not likely to eat this pattern. But more impressively, the southern pattern is very strongly correlated to education. So people that did not graduate high school are much more likely to adhere to this southern pattern than people that graduated college, which for us, college graduate would mean like a bachelor's degree. The alcohol pattern is much more commonly consumed in the college graduates than it is the people that did not graduate high school. So again, education has an impact on what people adhere, what type of diet they adhere to. But what about stroke? So one of our first dietary patterns, dietary analyses was chicken. And we were looking at chicken and fish and whether or not it was fried or baked. So how much fat was in it. And I have to answer the phone calls when the participants ask about diet. The call center refers them to me. And one of the participants called and wanted to talk to me about my analysis, my scientific paper. And he said, "You've got it all wrong. It doesn't have anything to do with fish. It doesn't have anything to do with chicken. It's specifically fried chicken." And I asked him why. And he said, "Well, my wife, when I was 20 years old, she saw a TV show that told us that you can't eat fried foods, that fried foods will kill you. So she quit frying food." And in the South, that's a big deal. Everybody fries. We fry cookies in the South. We fry every cake. You name it, they fry it and eat it. He said, "My wife saw that and she quit frying food for me, and that was 60 years ago. And he said, she was right. Now everybody knows that you can't fry food. But 60 years later, none of my friends' wives love them. So they still fry, hoping that they'll die." So it was this very interesting conversation, and where he just was very sweet about it. But what about stroke? How are dietary patterns related to stroke? These dietary patterns, all 5 of them, although we modeled all 5 of them, only 2 really showed up as being associated with stroke. And the first was that healthy pattern. The healthy pattern is pretty protective of stroke. You can see if you compare the 4th quartile, which would be the highest adherers to this pattern, these hazard ratios are all in the direction of being very protective. Once you add in smoking and sedentary behaviors, you lose statistical significance, but it's still in the direction of being protective. The southern diet is the opposite. So adhering to that southern style of eating increases people's risk of stroke quite a bit, all the way across the board up to the 4th quartile. But more importantly for us, again, Regards is supposed to test these interactions between race and region. And in our case, we are looking at how much does eating a Southern style diet explain the black-white disparity in stroke. And you can see that it's about a 63% reduction in the parameter estimate for race. So Southern diet pattern is one of the things that's probably contributing to these excess racial differences in stroke. These were the food groups one more time. But what could these patterns actually be measuring? I mentioned that the diet is very complicated. There could be genetic reasons to why we eat. We have food preferences and aversions. And the Harvard group has actually recently shown that there are certain enzymes that may or may not be expressed in people, and they may not want to eat fat if they don't have a certain enzyme profile in their gut. So there may actually be genetic reasons for what you eat. Socioeconomic status, what your parents ate, what your grandparents ate, how you learned to cook from your mother or your father or your aunt, all of that can influence your dietary pattern. And these things can come forward with us all the way from childhood into adulthood. The other complicated thing in the US is intention to lose weight. We are inundated with weight loss in the United States. Constantly, somebody comes out with a new weight loss strategy to try to get us to be thinner, yet we get fatter and fatter and fatter. So this pattern seems to be continuing of intention to lose weight. And that makes it complicated because people will change what they eat because they want to lose weight. What about family and the environment? Stroke is a really complicated disease. Once someone has a stroke, you're often left with your family members who are going to prepare food for you. 80% of the food we consume is usually consumed with other people around us, so we get our cues to eat from other people. And family support can be extremely important in getting people to change their diet. The built environment is what I focus a lot on these days. Looking at poverty, access to food, pollution. We actually buy the data from our space agency, NASA. We buy NASA satellite data for all of our participants. So we know what type of pollution they're having right at their home throughout the entire course of the study. Where someone lives affects their ability to move, opportunity for job. And there's so many ways in the United States to measure what's happening at the local level. We can use the county level mortality data. So do a lot of people around them die? Does that influence someone's risk of dying? We can also look at neighborhood socioeconomic status, or neighborhood deprivation as it's called. Again, using a factor analysis-like technique. In France, you have the IRIS data that you can buy and use a factor analysis to come up with some type of a score. We can do the same thing in the United States, which is what we originally did using it's called the census in the United States. We use 6 measures of the census to try to get a feel for what the neighborhood socioeconomic status was. Getting straight to the stroke outcomes, the neighborhood socioeconomic status is the first line. It was more strongly associated with risk of stroke than sodium or county level stroke mortality. You can see that as people lived in a wealthier neighborhood, as the score goes up, they live in a wealthier neighborhood, the risk of stroke dropped. So that in the 4th quartile, there was a much lower risk of stroke in people living in wealthy neighborhoods. Sodium intake was not that strongly correlated. We had to model sodium. It was the US government's trying to pull sodium out of our food supply and failing miserably. France and Europe are much further along than the United States. And we were trying to get them some data that they would need to help pull sodium out of cereal and bread and things where sodium does not need to be. At the county level, living in a county where other people are dying of stroke seems to put people at an increased risk of stroke, just slightly. And then I just want to lastly talk about what else we can measure in the United States. We can measure safety, so how safe is the neighborhood, how many break-ins are happening around the neighborhood, what's the murder rate in the neighborhood. Those are all things that are thought to contribute to excess stress, which might lead to excess stroke. We can look at access to mass transportation. Is there a bus or a train system that can get people where they're going quickly? We can look at how walkable the neighborhood is. We have neighborhoods that don't have sidewalks and are right next to very busy roads. So we can look at how walkable it is. We can look at neighborhood changes, how rapidly it's going from being an impoverished neighborhood to a very wealthy neighborhood. We call that gentrification in the United States. And is the word the same in France? Yeah. Chain grocery stores. We have these chain grocery stores that are considered not great in terms of the food that they offer, so we can look at how close someone lives to a chain grocery store, how close they are to a pharmacy, a gym, a park, all different types of things. And each of these measures, we can look to see how they impact stroke risk. We're in the process of assembling all this data right now, and hopefully we'll have something in the next 2 to 3 years to discuss. In regards in the future, other things we're working to do, we're working to validate our measure of cognitive functioning. We've got a second dementia assessment that we're doing in people's homes. We've got some functional measures in terms of timed walk, chair stand, and a digit symbol test. And we just did a second visit in people's homes, so we've got a second round of biomarkers and blood pressure, urine, things like that, that we can do other outcomes on. And that was all that I had for today. Are there any questions?
Thanks a lot, Suzanne. It was very nice. It's an amazing cohort. Congratulations. I had a question regarding your finding on diabetes. So why did you look at the interaction? And if you think it's relevant for cognition, why wouldn't it be relevant for stroke?
That's a great question. The cognition happens the changes in cognition happen much earlier. So we can actually detect changes in cognition at about age 55, where the strokes don't start happening until much later. So that's one reason we think that there might be an interaction. We tested it originally because when you put diabetes in the model, the point estimate would switch directions. So Mediterranean diet was protective unless you put diabetes in the model, and then all of a sudden it became a hazard. So we knew something weird was happening with the variable, and that's why we tested for interaction. It was not a priori when we put diabetes in. Recently, though, people have been saying, they call it type 3 diabetes. Have you heard this terminology over here yet? It's this idea that exposure to high insulin impairs cognitive function by itself. So, and it's not actually clinical diabetes, it's just high circulating insulin. So recently we've started testing for insulin, high insulin levels, and not just whether or not they say they have diabetes or take medication to control it. But stroke is a good question. We're still trying to convince people that cognitive function is a risk factor for stroke, that changes, that declining cognitive function is a stroke risk factor. We still get laughed out of national meetings when we say that. I know that's why we actually come to the European Stroke Conference more than the American Stroke Conference, because what we do lines up much better over here. Yeah.
So yeah, thank you very much. It's really a wonderful study and a brilliant presentation. The difference in systolic is quite large between blacks and whites, because 5 millimeters is quite large. So
on average, absolutely.
Did you calculate the increased risk, attributable risk to blood pressure between black and white? We did, actually. That's George Howard did all that work, and I should have put those slides in because it's fascinating. Blood pressure, systolic blood pressure is also a big contributor. It contributed to about roughly 50% of the racial disparity in stroke, slightly less than diet, but still a big contributor. And we looked at it in 10 millimeter of mercury blocks. People who have blood pressure in the 160s, if we just look at people who are 160 and above, African Americans are 4 times as likely to have a stroke in that 160 millimeters of mercury. So it doesn't matter what level of blood pressure you're at, unless you're under 120, at every stage, African Americans have much greater risk of stroke with that high systolic blood pressure. And there was only 11% of hemorrhagic stroke, right?
Yep.
Which is not a lot.
No. Hemorrhagic stroke is not the prevalent form of stroke in the United States. Ischemic is much more common. We actually have additional data that I'd be happy to share looking at incident risk factors. We're trying to figure out why do blacks have more hypertension. That was our second round of funding, was trying to figure out the difference in hypertension prevalence. But that data has just been published this year. And again, diet was the primary factor. George Howard, who's the original PI of the Regard study, he never thought diet was going to be any kind of a factor whatsoever. In fact, when we had to do cognitive functioning tests, he didn't want to fund diet anymore. He said, let's not study diet. So that's when I came into the study and I said, no, please, we have to study diet, trust me. And it's turned out to be a bigger factor. So
and you have an evaluation of the salt intake in the diet? Or in the
we do. It's not great, though. It's off that food frequency questionnaire. We have stored urinary sodium. We should measure it. And we can also get urinary aldosterone from that. But we haven't done it yet.
I had another one.
Yeah.
In your stroke belt, Florida is an outlier. And what does that tell you on, I mean, is that any help for a control group? Or
Florida is an odd state.
Yeah.
Florida.
They vote strangely.
Yes, in many ways. So Florida was not actually a part of the United States when the southern part of the United States was being annexed and the plantations and agriculture. Florida was actually a part of Spain. So the demographics of Florida are very different than the rest of the Southeast. Those of us that live in the Southeast, we don't consider Florida to be a part of the Southeast because they are so different. It's much more, there are many more white people living in Florida. Lots of retirees live in Florida. People spend their whole life in New York and Michigan, and then they move to Florida to retire. So it's just an odd state in terms of...
So it can't be used as a
No, it really can't. It really can't. But it's a lovely state, tons of beaches.
Yes.
Disneyland or Disney World.
Yes. Stones.
Yeah. Uh-huh.
Des questions? C'est toi qui fais l'animation.
So maybe you could explain to everybody what are your plans here in France with this study?
Yep. So I'm looking to use dietary data and a measure of social deprivation to look at the joint effect of diet and social deprivation on risk of stroke in the 3C study. We've got some preliminary data, and it's actually going pretty well so far.
For the deprived people? Or?
Well, not for the deprived people. The analysis is going well. So that's the goal here, to compare what we might see in France with things I've seen in regards in the past.
Excellent.
And you're all invited to Alabama, just so you know.
It's time to eat fried food.
Yes. Thank you very much.